Hello, everyone. My name is Anuj Gupta, and I'm a third year osteopathic medical student at Kansas City University. Today, I will be presenting a case report on the diagnostic challenges of acute onset neuropsychiatric symptoms in a pediatric patient with congenital brain abnormalities. Acute onset OCD and motor tics in children can have multiple causes. Some common examples include pediatric autoimmune neuropsychiatric disorder associated with group A strep, or PANDAS. PANDAS is a subset of a broader disorder called PANS, which is pediatric acute onset neuropsychiatric syndrome. And other causes that may play a role are neurological, metabolic, and other primary psychiatric disorders. This case highlights the complexity of a neuropsychiatric diagnosis in a child who has pre-existing congenital abnormalities. Our patient is a 6-year-old male with past medical history significant for agenesis of the corpus callosum and congenital hypothyroidism. His family history is also significant as both parents have severe OCD. He presented to clinic with new behavioral changes that gradually worsened over time within a short time period. A comprehensive neuropsychiatric evaluation revealed sudden onset compulsive behaviors and motor tics. In addition, he was complaining of intermittent throat pain just prior to the development of these symptoms. Given his symptoms and his recent throat pain, PANDAS was initially suspected. However, this case was not as clear or straightforward as we thought. A rapid strep test was performed and found to be negative, which made the diagnosis of PANDAS much less likely. PANS is a diagnosis of exclusion, and there was no obvious trigger for it. We had to consider numerous factors, including other infections, autoimmune, metabolic dysfunction, as well as the patient's family history of OCD, and also consider how the patient's medical history of agenesis of the corpus callosum and congenital hypothyroidism may play a role. Labs and imaging were ordered as part of the initial workup. Lab work, including CBC, CMP, and thyroid panel, were normal, and a head CT with contrast showed no new abnormalities. Given these findings, a diagnosis of PANS was made, potentially due to multifactorial etiologies. As far as management for this case, a multidisciplinary approach was taken involving pediatrics, neurology, and psychiatry. Pediatrics ensured primary care follow-up and referrals to specialists. Neurology was consulted and recommended observation unless the patient developed new symptoms such as altered mental status, a new focal neurological deficit, or seizures. And psychiatry recommended cognitive behavioral therapy for both the patient and involve the parents in it. Some lessons that take away from this case. The sudden onset of neuropsychiatric symptoms in a pediatric patient may occur even if there's no obvious infectious cause for it. A patient's medical and family history should always be considered. Avoid premature diagnosis of PANDAS, especially when group A strep is ruled out. Always consider other diagnoses, including metabolic, neurological, autoimmune, and psychiatric. A multidisciplinary approach involving neurology, psychiatric, and pediatrics is essential. In conclusion, this case challenges us to think beyond PANDAS and explore rare causes of acute onset neuropsychiatric symptoms in a child. Clinicians should consider other causes such as congenital or genetic or psychiatric, autoimmune, or metabolic if PANDAS is ruled out. Future studies should investigate the link between congenital brain defects and how it may play a role in development of neuropsychiatric disorders in children. Future studies also need to establish clear guidelines on the diagnosis and management of PANS. Thank you for listening to our presentation.